Shalom. Welcome again to Seekers of Meaning, the podcast TV arm of Jewish Sacred Aging. I'm your host, Rabbi Richard Address. Sleep. How much do we need as we get older? What are some of the challenge of it? What's the literature saying? Part of our growing older is an adjustment, perhaps, for some of us of different sleep patterns. And what does it mean? And should we get worried about it? And what about if we take our little friend to bed with us? Lots of issues now coming up about sleep and the importance of sleep or the lack thereof and changes. And so we decided today to take a look at this with an expert. And we are very, very pleased to welcome to today's Seekers of Meaning, Dr. Angela Skrzynski, a board-certified sleep medicine and family medicine physician who specializes in digital health and insomnia. Just what we are hoping for. So I hope all of you are awake for this. Doctor, thank you. Angela, thank you very, very much for coming and joining us. And
thank you for having me, Rabbi.
You write in the introduction that you sent us for today, this wonderful sentence about sleep. You say, sleep, I believe, is the foundation for better wellness. Sleep is the foundation for better wellness. What do you mean?
Yeah, let's unpack that a little bit. So as a family medicine and sleep medicine physician, naturally, I think sleep is important. So maybe I have a little bit of a biased view. But what I hear from my patients who don't sleep well, and I hear it again and again and again, is that lack of sleep goes on to impact every aspect of their health. And what I'm talking about is not having the energy to engage with your family and your friends in the way that you would have liked to. I don't have the energy to work out and to go to my doctor's appointments because I'm just exhausted. I spend a lot of my time worrying about sleep. And because I don't get enough sleep, it's hard to manage my mood. I'm irritable. So you see the repercussions and the ripple effect into their social lives, their spiritual lives, their physical health. And it really impacts. And many of us who sleep well can understand this, right? Because we know what the impact of poor sleep is when we've had it only, for a few nights in a row. We understand how that feels and what that does. And I don't want to catastrophize either, because it's important that we understand that you can have a full and meaningful life even with poor sleep, and it does not kill you. And you can move on, but it also does not need to be that way. There are so many ways in which we can improve our health and our wellness and go from surviving to thriving, and sleep is one way to do that.
So I got to ask you, because it's curious, what got you interested in sleep? Of all the specialties that perhaps are open to a young medical student, and you, if I'm not mistaken, you were trained at Michigan, right, in Ann Arbor?
Yeah. So I did my family medicine residency in Philadelphia.
Oh, okay.
And I did a rotation with an ENT and sleep medicine doctor who I thought was great. And I don't know that I can even describe it in words, but the idea of studying people's sleep was just fascinating to me. It's in the same way that some people love Legos, or, there was something about it that really drew my interest. And so, and in your family medicine residency training and in any non-sleep medicine training as a physician, you really don't learn much about sleep. You really don't. It's very little. And I didn't even really have a good grasp on what a sleep medicine fellowship would encompass. But I knew that I had enjoyed what I had seen of a sleep medicine doctor treating patients and helping them on that journey. And it was very fruitful for me. It ended up being something that, I think is very interesting and I'm also really passionate about. for the reasons that I outlined. But yeah, it was a really cool year. And yes, I did my sleep medicine fellowship at the University of Michigan in Ann Arbor, which was a great experience because it is one of the largest and most renowned sleep medicine institutions, which allowed me a lot of access to all types of patients and conditions. And it was just it was a great training program, and it was a lot of fun.
So it's fascinating how people make choices. So you've studied this. This is your practice. This is your passion. So as we get older, the literature is saying, well, our sleep patterns may change. We need more sleep. We need less sleep. What's the truth?
Yeah. So that's all true. As we age, our sleep patterns change. We tend to listen, sleep is different, just like everything else, from one human being to the next. So it's going to be very individualized. For some folks, as they age, they find the typical pattern is that they sleep a little bit longer. They get tired a little bit more easily. Maybe they begin taking an afternoon nap, which no longer impacts their nighttime sleep like it did when they were younger, right? When you're younger, maybe you take a nap in the afternoon and you can't sleep at night. And when we get older, we can typically do that sort of thing. But they also tend to wake up earlier. As we age, we tend to wake up a little bit earlier in the day. We also tend to be more prone to having some sleep conditions like obstructive sleep apnea, for example, which, if not treated, can have a significant impact on sleep. It can make it more disrupted. It can make it harder to fall asleep, stay asleep. And so that's a concern. And then also, as we age, some of the medications that we take, if we take any or if we take many, may also have an impact on the sleep architecture, we call it. So the different sleep stages that we're in, they may increase our likelihood of having restless leg syndrome. So, these are, when we're taking care of aging patients and managing their sleep, these are some of the things that we're thinking about.
So, I'm a big proponent now that I'm older of the post-lunch 10-minute nap.
Yep.
When I'm not working or out doing stuff and I'm home, I found it to be very, very beneficial and really energizing.
Mm-hmm.
Really energizing. So what you're telling me is that's pretty normal.
That's pretty normal. In fact, a lot of folks, as they age, take longer than 10-minute naps. And here's the thing. I mentioned already that sleep varies from person to person, and we have general guidelines, right? Like you mentioned, not bringing your best friend the phone into the bedroom with you. And that's very much what we recommend to people. However, I also have a saying when it comes to sleep: if it ain't broke, don't fix it. So if you're taking a 10-minute nap in the middle of the day and it's energizing you and you're sleeping well at night and you're functioning well throughout the day, you don't need me. Keep it moving. But there are going to be other folks who take a 10-minute nap in the middle of the day and, as a result, cannot fall asleep when they get into bed for bedtime. And so in that sense, everyone really is different and it has to be individualized, which is why it's so important that if you are having difficulty with sleep, that you're seeking that individualized care from a sleep medicine physician.
So I keep hearing about, and I mentioned this to friends of mine who are dealing with this sleep apnea thing.
Mm-hmm.
What is that?
Yeah.
What is sleep apnea? And I've also read articles that if just left to its own devices, and you alluded to this, it could create some very serious health issues. Could you walk us through this?
Yeah. So let's start with the name and let's take it piece by piece. So obstructive, there's an obstruction that occurs in sleep that results in apnea or a pause in breathing. And so what happens is many people think of this as, well, this causes snoring, right? Well, yes, it causes snoring because you imagine some air trying to get through an obstruction. It's going to make that vibrational snoring noise. And so what happens really is that when we lay down and we fall asleep with both the gravity of lying down, particularly on our backs, And also with what happens during sleep is our muscles relax. And so we lose some of the tone in our throat. So those muscles that are, and those structures that are helping to keep the airway open while we're awake and upright, they're not doing that when we are lying on our back or maybe even on our side and asleep. And so in most people, right, we're still keeping our airway open. But for those people with obstructive sleep apnea, it's not doing that anymore because they have a large tongue and it flops back, because they have a large uvula and it flops back, because their muscles are just not keeping tone. And so they're not keeping their airway patent anymore. And so it's not that you're consistently not breathing all night long. It's that you have these periods throughout the night of pauses in breathing. And so that creates that snoring. And sometimes you'll oftentimes actually hear a bed partner, someone who's sleeping with the person with sleep apnea, say they pause breathing in their sleep. It sounds like they're choking. It sounds like they're gasping for air, and they are. And a lot of times they'll wake themselves up with right? That kind of gasping sound. And so that is that obstruction and that apnea. So when that happens, it not only disrupts our sleep, whether we know it or we don't, it's going to cause a little bit of an awakening. And it may not be a true awakening that we understand as an awakening, but it's still causing an awakening. And it's changing some of your hormone levels, like cortisol, which is one of our stress hormones, or leptin and ghrelin, which are our appetite hormones. And those changes are leading to more serious things that are not just snoring and not just making us sleepy and not just making it hard to stay asleep, but also putting us at higher risk for things like heart attack, stroke, heart arrhythmias, erectile dysfunction, diabetes, high blood pressure. And so in that sense, obstructive sleep apnea is not at all a benign disease. It is not at all a disease where we just treat the snoring and, call it a day.
Well, I've never, it's interesting, and I thank you. I mean, you use your linking that sleep apnea is a disease. When I've talked to friends of mine, they say, "Oh yeah, I have sleep apnea, and it's just a condition, and I have this mask."
Yeah.
And I see on TV now there's a patch you can. I don't know. It's your profession. We didn't have that class at the seminary. We just tried not to fall asleep in class. So what's the story with all these masks and stuff? Is this? Do they work?
Yeah, let's get
into
into
what do
it.
they do? What does a mask do with somebody who's dealing with this?
They work. So CPAP is the primary gold standard treatment for obstructive sleep apnea. What it does, it's a mask, and these masks can take many different forms, is it simply pushes air into your throat to keep the airway open while you sleep. That's it. As you're trying to inspire, it detects that you're trying to inhale, and it is pushing air and just enough air, because it knows when it's achieved its goal, to keep that airway open for you. And so it can be delivered with a full face mask, right? Or it can be just a nasal mask, or it can even be nasal, kind of like prongs that, similar to what you see in the hospital when people are getting oxygen through a nasal cannula. And so they can be more or less sort of obtrusive or large, but they are very safe, extraordinarily safe, right? And they're very effective. And the technology has gotten so good now that they are these tiny little machines and these tiny little masks, and they have a headpiece that swivels as you move so that you can lay any which way. And if you got to go to the restroom in the middle of that, you just attach it here and go on your way and then reattach. And the machine is now able to detect what sort of settings you need, and it's able to even detect how well it's working for you. And so every morning you get a smiley face or a sad face that tells you how well it's doing, and it sends that information back to your doctor too, so that they can understand, what adjustments, if any, need to be made. It's a really, really cool thing. There are other treatments for obstructive sleep apnea on the market, as you mentioned, right? Some of the most popular things are the Inspire device and oral mandibular advancement devices. But the truth of the matter is, and anybody can look into those treatments as well. But the fact of the matter is, for I think the foreseeable future too, CPAP is the gold standard, safest, most effective treatment, the first thing anybody should be trying. And for those people who do not tolerate sleeping with a mask, and some people don't, there are programs for that too. You visit your local sleep medicine, usually a university hospital, will have a CPAP desensitization program, and they walk you through how to learn to sleep comfortably with a CPAP on.
We're speaking with Dr. Angela Skrzynski, a specialist in sleep issues, board-certified sleep medicine and family medicine physician, around this whole issue of the impact of sleep and the changes of sleep. And again, if those of you who are listening or watching would like to get in touch with us, please feel free to email me at rabbiaddress@jewishsacredaging.com. Visit the website, jewishsacredaging.com, the Facebook page, etc. If you'd like to help us and support the work of the podcast and Jewish Sacred Aging, on the website, there's a very conveniently located donate button, and we appreciate any support that you can send in there. It's tax-free donation, so thank you very, very, very much. Doctor, is there a recommended position? Is it better to sleep on my side, sleep on my back, turn over every once in a while? Or is it just say whatever works for you?
Yeah, it depends on what we're talking about. So we're talking about obstructive sleep apnea. By and large, people are going to do better sleeping on their sides. And in the rare case, somebody sleeps on their side, and that actually does the trick. They don't need to use a CPAP machine. And so in those cases, we can actually prescribe a sleep positioner device. Kind of looks like a shark fin that you wear to bed that doesn't allow you to get on your back. Really, like, putting pillows and propping you up really doesn't do the trick. So there are all of these kinds of things. When you're talking about like a pregnant woman sleeping, we like them to be on their side too, usually on their left side. But for all other folks who don't have obstructive sleep apnea and aren't pregnant, you can sleep whichever way works for you.
So this concept, this word insomnia, part of your specialty. And but parenthetically, are there a lot of Dr. Angela Skrzynskis in the country, of people who just specialize in sleep medicine?
There are not that many. And so that's actually one of the problems. It's hard to get the sleep care that you need. So it's fairly easy to get a sleep study performed, right? To rule out things like obstructive sleep apnea. Your primary care doctor can order that for you, and you can go to a sleep lab and have that done. Or, they can set you up to do it at home with a home study. So that's fairly readily available. But then to see a sleep medicine specialist is much harder. It's long wait times, and I don't know the exact number. I remember hearing it once. I think it's on the order of only hundreds of us in the country.
Wow.
Yeah, it is small. There are not that many fellowship training programs, and they train, a handful of folks every year. And so at each one. So it is a small number. And so when I was thinking about insomnia treatment, which is really I told you that sleep medicine is my passion. This is like my passion. I really enjoy treating insomnia. There are millions and tens of millions of just adult Americans who struggle with chronic insomnia. And about 5 to 10% of people develop it each year. So it causes a humongous burden of illness in this country.
So
And
you define what, because sometimes say, well, I have trouble
yes,
falling asleep or I get up a couple
sure,
of times.
sure.
That's not insomnia, is it?
There's acute insomnia where you
Yeah.
have some difficulty sleeping for a shorter period of time because maybe you have some back pain or maybe you just got some really hard news. But then there's chronic insomnia. And this is a consistent difficulty with either falling asleep, staying asleep, or waking up earlier than you would like to. And it has to result in some sort of distress. Like it's got to bother you. If you're having a lot of trouble sleeping, but you're waking up feeling great and yeah, okay, I can only sleep 2 hours a night, but it doesn't bother me. I don't know many people like that. Then it would not be considered insomnia. But if you're having this consistent, lasting weeks to months and longer difficulty with sleep, that is considered chronic insomnia. And that is really where we treat, right? We don't really treat the acute insomnia other than to say, hey, we got to fix your back pain, get you through this difficult time. It's a huge burden of illness. And as we discussed, it's also a huge impact on productivity at work, social life, right? It just, if we could get everyone sleeping well, I can't even imagine how much more we would accomplish as a country because so many people suffer and struggle. And so when I was thinking about how to get more insomnia care to more patients, that's when I developed my sleep medicine insomnia practice, sleepprocbti.com. And it was really around exactly what you talked about, the fact that there aren't that many of us and to treat it, and yet there are so many who need it.
What this pardon the elementary fundamental question, but what causes it? Is this genetic or is it environmental or is it all of the above or?
Yeah, not any genetic basis that we're aware of, but it's very widespread. And there are many different causes to insomnia. It can be related to the medications that you're taking. It can be related to chronic pain, how much you have to urinate. But honestly, most commonly, this is very frequently associated with anxiety, depression, just even not diagnosable anxiety, but general stress. There can be different things that interrupt your sleep, like babies or pets or an ailing family member that you're caring for. And eventually that sort of sleep pattern kind of becomes habitual. Poor sleep hygiene, AKA things like bringing your phone into the bedroom with you and other practices that you have around sleep can affect your ability to sleep well. It's more common in women. It's more common as we age, but there are many, many, many reasons that you can develop insomnia.
I have to ask you the next question before we get into the digital stuff. Because if you go to the local drugstore, there's a whole shelf
Oh, yeah.
of melatonin. Take this, you'll have the best night's sleep of your life. Go to the dispensary and take a gummy.
Mm-hmm.
Or how much of this is true and how much of this is, I want this to be true, so I'll take this medication or I'll take this drug.
Mm-hmm. Mostly not true. So if you ask the average person with insomnia how they're doing with their sleep aid, whether it's a prescribed sleep aid or a marijuana gummy or some other supplement that they found, they're often going to tell you that it's working well for them. But the studies say otherwise. And not only is it not that effective, it becomes less and less effective over time. What happens is these sleep aids become a psychological crutch. I need it to go to sleep. And then we become very dependent on this sleep aid and we let our behaviors around sleep lapse and our thoughts around sleep lapse. And we develop sort of deeper and deeper insomnia. And now we need higher and higher doses of whatever we're taking over time in order to sleep. And eventually it stops working or we can't tolerate it because of the side effects. So sleep aids, contrary to very much popular belief, including in the healthcare industry, are not the first line method for treatment. sleep aids should be used in really very rare circumstances, like for acute insomnia, for example. What we really should be doing for people who struggle with insomnia, about 90 to 95% of the time, what we should be doing is something called CBTI, or cognitive behavioral therapy for insomnia. And the problem is that most people have never heard of it. There are millions of people suffering, and most people, including doctors, have never even heard of the number one treatment, the safest treatment, the most effective treatment, the cheapest treatment, the best treatment for this problem. I had never heard of it until I did my sleep medicine fellowship.
So walk me through that. And you do this, and your practice is, if I'm not mistaken, in large part electronic. Is that correct?
Yep. So in that practice, I only do this, and I only do it digitally. So let me back up for a moment. I told you that my background is in family medicine and sleep medicine. And I have the pleasure of serving as the lead physician for telehealth at a large health system in New Jersey. And I was your traditional family medicine doctor before COVID hit. And then when there became a need and a demand for digital services, I sort of moved into that arena, and I've stayed there ever since because I enjoy it so much. And so I became very deeply involved in telemedicine and other digital health offerings. So a couple of years ago, I thought, well, I love digital health, and I love insomnia, and it's very hard to find CBTI. I mean, I told you how hard it is to find sleep medicine care, but then finding CBTI is that much harder. Oftentimes people are going a couple of hours away to their nearest university health center to receive this type of treatment, and they're driving there weekly, and they're very frequently seeing someone who has maybe taken a few week-long course in CBTI, as opposed to somebody who has a really, really deep understanding and has really had some extensive training. So it was sort of all of these problems that I was trying to solve, the access to this care. And so I created what I think it's much easier to see somebody via telemedicine. It takes a lot of the barriers to care out of the way. And so I created sleepprocbti.com, which is, it offers group and individual CBTI sessions to patients via telemedicine. And so that was my solution. Fun.
So a couple of questions.
Yeah.
Number one, because this may be totally, out of the ordinary to a lot of people who are used to going to the doctor's office, or even some who now do telemedicine with their doctor. If they have I got flu, I don't want to go out. What do I do? Yeah, here's a prescription, go to the drugstore. So number one, you do this, you see patients on the computer. So do you bill Medicare? Is it insurance? Do you cover it? So it's all fee for service?
It's fee for service. It's not covered by. I will create a super bill, and then patients can submit it to their own insurance. And much of the time it does get covered because insurance does cover CBTI.
Okay.
But I don't take that on myself.
Second question. So you obviously then, since you're in Jersey, do you see patients across the country?
Right now, New Jersey, Pennsylvania, and Michigan. Soon I'll expand to Delaware, and who knows what happens in the future after that.
Is that because of the licensing?
Yes.
That you can't treat somebody in New Mexico because you're not, quote, licensed in the state of New Mexico?
That's exactly right. And this is a problem with the healthcare system today. But
no, I've run into this with therapists who say, yes. I can treat, I'm licensed in these three states, but if somebody calls me from California and I'm not licensed, I can't do it. Okay. So if somebody wants to get in touch with you what's the site? What's the email? How do they do that?
So you can visit me at sleepprocbti.com, or you can
So
email
that
me
gets
Sleep Pro, SLEEPPRO, and then it's CBTI, like cognitive behavioral therapy for insomnia.com.
Okay.
Can also email me at info@sleepprocbti.com. And on my website, you can find a lot more information about insomnia, about CBTI, about my particular program. And you can schedule one of three things. You can schedule the sessions, which are 6 weekly sessions, and it includes 1 year of unlimited support afterwards. Or you can schedule a free consultation with me, or you can schedule me for a speaking gig if people are interested in, educating a large group of folks. But I really like doing the free consultations. I think, generally speaking, that's the best place to start because it allows you as a prospective patient to sort of to vet me, understand the program better. And I also get a better understanding of what the needs are. And it's a really nice launching point, and there's really nothing to lose aside from a little bit of time. And then we really can hit the ground running when we start our sessions.
Wow. So thank you very much. I mean, this is,
Thank you.
we take sleep for granted in so many ways and until it's interrupted. And it's nice to know that, hey, there's an expert who's available. So thank you. I really do appreciate this. I'm sure we'll be back because I want to eventually explore some of this digital, because
I'd love
it
to.
obviously is the way of the future and it's here.
Mm-hmm.
And it's probably a good conversation to have. But Angela, thank you very, very much. I appreciate this.
Thank you, Rabbi. Thank you for having me on. Appreciate it.
I'll see you on the highway there.
See you soon.
Say hello to the family.
Will do.
To all of you, thank you very, very much for joining us on today's edition of Seekers of Meaning, the podcast TV arm of Jewish Sacred Aging. And again, if you want to contact us with an idea, just email me at rabbiaddress@jewishsacredaging.com. Visit the website or the Facebook page. Seekers of Meaning is produced at the Broadcast Center of Lubetkin Media in Cherry Hill, New Jersey. And a big thank you to our producer, Steve Lubetkin. Once again, until we see each other on the next Seekers of Meaning, take care of yourself, be safe, be healthy, and most of all, be kind to one another. Todah Shalom. Thank you.